Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds, Premier Education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, it's a great delight for me to present my colleague, Dr. Alexander Lyon, to discuss and inform us a little bit about cardio-oncology and lung cancer. As you know, Alex is already a very famous and very well-known personality in this field, and we look forward to your talk. Alex, over to you.
Eric, thank you very much for your very kind invitation. It's a real privilege to speak at your famous Royal Brompton Hospital Grand Rounds, and welcome to everybody from all around the world who's logged in to listen to the lecture. And I think the real take-home message is about how we work together, isn't it, Eric? And communicating between thoracic surgeons, lung cancer oncologists, respiratory physicians, and cardiologists who have an interest in the outcomes of your patients, so we can improve long-term outcomes, both from an oncology perspective and cardiology and cardiovascular perspective. Those are my disclosures. So really, this is about us sharing patients. You know, we've trained in different parts of the medical education system. We often have different departments, often in different buildings even. And yet we're sharing more and more patients. Our patients, cardiac patients, are surviving their myocardial infarctions, their heart failure, strokes, and arrhythmias to live to get cancer, and then come to your operating theatres or your oncology clinics with all that cardiac comorbidity. And likewise, there are a lot of shared risk factors, and therefore a lot of undiagnosed cardiovascular disease in patients at the time they present with lung cancer. And then we've seen a revolution in the treatments you're offering, and those treatments often can have adverse effects. And that's really where we've become a specialist field. I think when we went back to medical school, we'd have had maybe 1 minute of one lecture and a small paragraph in the big textbooks which we were learning from, saying the red chemotherapies cause heart failure. High doses of radiation to the chest can cause coronary disease, valve disease, pericardial disease. And there were these fluoropyrimidines that cause some chest pain syndromes. But this is what modern cardio-oncology looks like. Every drug on this slide has led to either a cardiac or vascular complication, and the patient being referred to our cardio-oncology service at the Royal Brompton Hospital. And every month or two, I've got to add a new drug because oncology is busy developing lots of effective new drugs that become licensed. And now 1/3 of every FDA licensed cancer drug, 1/3 of them have a cardiovascular complication. And the latest drug over here on the column under HER2 targeted therapies, which of course has got trastuzumab, Herceptin at the top. That's one of the poster childs because it's been around for 20 to 25 years. Zongertinib is now licensed for HER2 mutant lung cancer, but is causing cardiac problems. So I've just now highlighted the drugs that are licensed for different lung cancers that are keeping me busy in our service at the Royal Brompton Hospital. So it's really important we have specialist knowledge on how these factors help. It started with heart failure, but we now realize that almost all cardiovascular diseases can be caused by different cancer drugs. So a lot of hypertension, which I'll mention, QT, which I'll mention, of course, pericardial diseases. We've always known about malignant pericardial effusions, but now we also see checkpoint inhibitor pericarditis that can present with large effusions and tamponade. Atherosclerosis, common particularly in your smoking lung cancer patients, that can be accelerated by different cancer drugs, and then even thrombosis in what would be apparently normal vessels, pulmonary hypertension, and valve disease. Just give you a background on our service at the Brompton. We started it in 2011. It was the UK's first ever service, so we've now been running over 14 years. We developed the growth of the service from 2 consultants to then having a fellow, a nurse. We now have a GP with a specialist interest that connects our secondary tertiary care to primary care in the community. And then we were awarded a Centre of Excellence Award from the International Cardio-Oncology Society. And this also led to then funding that's allowed us to build our research centre of excellence. And what we've developed over the years is really coordinating a multidisciplinary service with lots of different teams within the hospital because of multimodality imaging, lots of range of cardiac problems. But you'll see here we have thoracic surgery because we work very closely with Eric and his colleagues. We're referring them patients who have pericardial effusions needing thoracoscopic pericardial windows, and he's referring a lot of patients either for preoperative assessment when they have a high baseline preoperative cardiac risk, or postoperatively with his novel monitoring, which I will show you later. But lots of different elements. So really, cardio-oncology, we're connecting lots of different parts of modern cardiology, cardiac surgery, thoracic surgery to bring together and deliver this. And when we did our audits, we found that actually of all the patients who had stopped their effective cancer therapy because of a cardiovascular complication, 88% we could get back onto treatment and complete their treatment safely. And this has led me as a specialist and our team to realize that although we start from a perspective of cardiology and wanting to improve cardiovascular outcomes, what we're actually doing is also improving cancer outcomes by ensuring people can have their best evidence-based cancer therapy safely, whether that's their major thoracic surgery and ensuring they proceed through that safely from a cardiac perspective, and then their long-term outcomes. And if they're developing complications from their treatments, that we pick them up early or ideally even prevent them so that they can have long-term the best oncology treatment. We have to deliver this quickly, so we have a target of seeing new referrals within 2 weeks, and we collected patient feedback, and the patients very much appreciate our specialist care model. And there's lots of communication. So one take-home message, if you want to deliver this effectively in your hospitals, is you've got to build the relationships and have communication between the cardiologists and the oncologists and the surgeons and the physicians to have MDTs to discuss complex patients, where often there is a real sort of weighting of the risks and the benefits of different treatment approaches. And this field has exploded. This is just a snapshot of a 5-year window of audit from 2016 to 2021, and you can see the exponential growth with a 10-fold increase. And if I tell you from 21 to 2024, there was another doubling. So this is a busy field with as patients are getting older. So we're having a lot of patients with multi-morbidity, more and more of those cancer drugs causing cardiac problems, and of course awareness. People realizing that we can help and referring high-risk patients before their surgery or before their chemotherapy or oncology treatment, as well as just reacting. Trying to be preventative is key. I had the privilege to chair the first ever European Society of Cardiology guideline, together with my colleague Teresa Lopez Fernandez from Madrid, and we brought together a group of world experts, cardiologists, hematologists, oncologists, there's even a patient, radiation oncologists, and published this guideline, which is open access, and it's for all of you as a reference document on how to approach patients with cardiovascular complications of cancer therapy. And the central figure from the guideline really highlights an important message, which is firstly that the risk isn't the same for everybody, and the second is that the risk of cardiac disease can change through the journey of the patient. So if you take the blue line at the bottom of this graph, a low-risk patient from a cardiac perspective starts cancer treatment. If they're exposed to a cardiotoxic drug, their risk goes up. But if they're well, then completion, they remain low risk. A purple patient, high risk at the beginning, higher during exposure, and then if they survive, they remain high risk. And then the dotted lines are the people who get complications from their treatment, the cardiovascular complications, which can be fatal or serious during treatment. And if they survive, there can be a legacy effect of late effects. So, of course, what we want to do is identify the purple group, the high-risk patients, before they start, so we can try and reduce their risk and maybe monitor them closely during their treatment. So a personalized medicine approach. And then in your survivors, after their surgery, after their chemotherapy and their targeted therapies or immunotherapy, who's high risk and should then have a cardiovascular review. So is this relevant to thoracic malignancies and lung cancer? Well, yes, if I just look at this slide, you're using radiotherapy, different inhibitors for targeted mutations, EGFR, ALK, then more general VEGF inhibitors. But the big explosion has, of course, been immune checkpoint inhibitors, which I'll discuss because of their cardiovascular issues. So if we just look at radiotherapy, we've known for many years that the heart, if it's exposed to radiation, this can lead to long-term problems. And of course, many lung cancers sit close to the heart, and therefore it's inevitable the heart is exposed. And when I'm teaching my fellows, I talk about radiation as like petrol on the fire of pre-existing coronary disease, because coronary disease is an inflammatory disease. So of course, if atherosclerotic plaques are exposed to radiation, it's going to activate oxidative stress and accelerate events. And this study shows this. So here in the red arms are the people with pre-existing coronary disease before their lung cancer radiotherapy versus in blue the patients without known clinical coronary disease. And here on the y-axis is major adverse cardiac events. So this is often myocardial infarction, heart failure, arrhythmias. And you can see over a 5-year follow-up from the radiotherapy that clearly people with pre-existing coronary disease have many more cardiac events. If we look at targeted drugs, ALK and EGFR inhibitors, in the guideline, we produce these summary tables. So these are like a reference table for you to use, where along the top are the different cardiovascular complications, hypertension, hypoglycemia and diabetes, dyslipidemia, heart failure, sinus bradycardia, atrial fibrillation, QT prolongation, and venous thromboembolism, so DVT and pulmonary embolism. And you can see the size of the bullseye reflects how frequent this risk factor is or complication is. And you can see for each drug, they have a different signature. Now, sometimes there's a bit of a class effect, like here, the diabetes with ALK inhibitors. But the point here is that if you're prescribing a patient with one of these drugs, you can use this as a reference document to just think. And for the cardiologist, refer to patients where they're on one of these drugs, you can go and see what potential problems there could be. Now, one of the big trials comparing two ALK inhibitors, brigatinib against crizotinib, published in the New England Journal in 2018 for ALK-positive non-small cell lung cancer, showed us, the cardiology world, what the rates of the different complications are. So if you take the brigatinib arm and look at hypertension, you'll see it's almost a quarter, 23% of the brigatinib arm developed new hypertension, of which 10% was complex hypertension needing 2 or more drugs. There was a lower rate in the crizotinib arm, which may be closer to what the background rate is. Conversely, if you look at sinus bradycardia, a lower rate in brigatinib, but this is higher in crizotinib, and also this fluid retention that doesn't seem to be sort of a hemodynamic cardiac problem, maybe more a vascular leak syndrome causing fluid retention and edema. But of course, when patients present with edema, there's always a wide differential diagnosis we need to consider. But thinking of a sort of drug-induced edema that's separate to renal failure, separate to heart failure, must always be considered if the patient's on a drug like crizotinib. And then we've seen this real impact of this third generation EGFR inhibitor, osimertinib, which, as of course you know, is now licensed not just for metastatic EGFR mutant lung cancer, but now used more and more in the adjuvant setting as well. And the first sort of study started to emerge that there was a signal of cardiotoxicity. Here's a study showing that in these reported events in a system in America collecting through the FDA, they saw that there was a rate of QT prolongation, which is about 6.6-fold higher, a rate of heart failure 2.2-fold higher, and a risk of atrial fibrillation. But of course, it's all about what's the comparator, and the comparator was other TKIs, and they may already have an elevated rate compared to the non-treated population. So one has to think of this about, first of all, the rates of these complications against the whole database and then other TKIs. But you'll see that depending on which topic or complication you see, that there's a range of cardiovascular issues. And the one that we've been most interested in is heart failure. This was a more specific phenotyping study from Japan, because as I'm sure many of you know, EGFR mutant lung cancer is much more common in Japan compared to other populations, and therefore they've had been ahead of the world in developing EGFR inhibitors. And they reported 123 patients on osimertinib, of which just under 5% had a severe adverse event, and it was mainly heart failure. And we think that this is because osimertinib blocks the HER2 pathway as well as EGFR, and HER2 is the target of trastuzumab, Herceptin, which we know causes left ventricular dysfunction or heart failure in about 16% of people exposed to Herceptin, and therefore this may be the mechanism of this EGFR inhibition with osimertinib also inhibiting HER2. Not surprisingly, if you've got pre-existing heart disease, you're greater risk. And so they published the cardiac dysfunction. As the heart enlarges, then you can get progression of valve disease and also a case of an acute myocardial infarction. Moving on, another topic which keeps oncologists focused is QT prolongation, because there's been a long history of cancer drugs causing significant QT prolongation, which of course can lead to torsade de pointes and then sudden cardiac death. And in our guideline, we have this table summarizing the drugs with the highest risk, but also drugs with a moderate risk. And you'll see there are several of the lung cancer drugs, brigatinib, ceritinib, crizotinib, and osimertinib, that do prolong the QT interval. And therefore, it's appropriate to have a baseline ECG, because you need to know what the QT interval is before you start the patient on their drug. And then in these groups of patients, consider who might need monitoring. And in the guideline, we have this algorithm. It's a very detailed algorithm, so I won't go through it all. But the principle here is that if the QT interval does prolong whilst you're on a cancer drug treatment, here we provide guidance about what to do. And the take-home messages are, if the prolongation still is below 480 milliseconds, we would say continue. If it's above 500 milliseconds, you definitely stop, because that's where danger is. And then between 480 and 500, one wants to correct the reversible causes and then do much closer monitoring to see if it resolves or whether it continues to prolong. And then after, if you have to stop the drug and allow a washout, then who can restart, and you restart at a lower dose and see if the patient tolerates it better. And this is all on our Pocket Guideline app. So I thought I'd give you a case examples of how EGFR mutant lung cancer patients could be approached, but this is a template you could use for all these different cancer drugs that have cardiotoxicity. So it's about who's at higher risk, and then how do we monitor them? And if we monitor them, what do we do? And this, again, comes from our guideline. So we have a range of technologies and tech tools for baseline risk assessment for cancer patients about to start drugs that we know have a high risk of either heart failure or left ventricular impairment. And here's the list of the drugs where we've created these specific pro formas. And they combine all these different types of risk factors: previous cardiac disease, the age of the patient, medical risk factors like diabetes and hypertension, lifestyle risk factors like smoking and obesity. Sometimes patients have had a previous malignancy with cardiac treatment or cardiotoxic treatments that might have a legacy. And of course, if you look at their heart with an ECG, an echo, and baseline biomarkers, you can detect disease, and that contributes to risk. And then for osimertinib, if we think it's working a bit like trastuzumab, inhibiting the HER2 pathway causing cardiotoxicity, we recommend that oncologists prescribing osimertinib use this risks pro forma. And essentially, you've got the list of the risk factors. Are they present, yes or no? And then there is a weighting. And depending on how many of these you have, you can then calculate, is the patient low, medium, high, or very high risk. And the ESC guideline has a guideline app. This is free of charge to download from the App Store. It's got all the cardiology guidelines, but for oncologists, perhaps the one you want is the Cardio-Oncology guideline, and then it has all these risk scores digitally within the app. And with a bit of practice, it takes about 60 to 90 seconds to sit down and do. So whether it's yourself, the consultant, or a fellow, or one of the nurses in your clinic, someone can do the baseline risk assessment. And for patients who are going to start osimertinib, we recommend all patients have a baseline echo, just as all women with HER2-positive breast cancer should have a baseline echo before starting trastuzumab. Because of this risk of heart failure, but probably somewhere between 5 and 8%, you need to know what the baseline ventricular function is. And we also provide guidance for people starting ALK inhibitors and the EGFR inhibitors about what else should be done before starting treatment. So a clinical cardiovascular risk assessment, I've mentioned the baseline echo before starting osimertinib. And then for the drugs that have a risk of hypertension, which I showed you in particular, brigatinib, and also crizotinib and lorlatinib, that they should start home blood pressure diaries. And you might have seen there was that signal of lipids with crizotinib and lorlatinib patients, particularly lorlatinib can get a very significant new hypercholesterolemia. And if they've already got coronary disease, you can imagine that's again petrol on the fire of their vascular disease. So monitoring cholesterol and treating it appropriately. And then for people receiving osimertinib, we should be monitoring their left ventricular function with echocardiography every 3 months. And for patients at risk of QT prolongation, then also consider ECG monitoring. If they're in a very high risk, say they've got a baseline QT interval that's prolonged, before they start a drug that prolongs the QT, you might want an ECG at 7 and 14 days. And otherwise, you can then reduce the frequency over time. And of course, for anyone on a drug that may cause QT prolongation, so a cancer drug, you need to be very clear to all the doctors looking after the patient not to prescribe other QT prolonging drugs like antihistamines, antibiotics, and a lot of this sort of antipsychotic and antidepressant medication in particular, to ensure you avoid other QT prolonging drugs and you maintain potassium, magnesium, and calcium levels in the normal range. So let's say you're monitoring a patient on osimertinib and they develop some left ventricular impairment. What do we do? Well, if they present with symptoms of this, then this is essentially some form of osimertinib-induced heart failure. We have this phrase cancer therapy-related cardiac dysfunction, or CTRCD, and I think that's more useful when we look at asymptomatic cases. But if they're symptomatic, one would have to pause the osimertinib. If you're in the oncology clinic, clearly refer them to your local cardiology service, and if you have one, a local cardio-oncology service, and that patient would receive heart failure treatment according to our guidelines with ACE inhibitors, angiotensin receptor blockers, or if their left ventricular ejection fraction is very low, then sacubitril valsartan, beta blockers, aldosterone antagonists, the SGLT2 inhibitors we're using more and more, that's dapagliflozin and empagliflozin, and diuretics for congestion. And then, depending on how the patient is, if we've stabilized them, then we discuss their case in an MDT with the oncologist and cardiologist to agree, would it be safe to restart the osimertinib? And if so, what dose? Is it full strength or a lower strength? It will depend on how severe was their heart failure, what is the status of their cancer, is it a metastatic indication or adjuvant? And if it's metastatic, how are they responding? But clearly, when you restart them, they're a high-risk case and need very much closer monitoring. What about if they've come along and had their routine surveillance echo, so they're well, but it detects LV impairment, which is new. Now, if it's severe, and we define that as an ejection fraction that's fallen from the normal range to below 40%, you'd pause the osimertinib and refer to cardio-oncology. And like the symptomatic patient, they'd get put on a lot of those heart failure drugs and then have an MDT discussion to start when we restart. What about if it's moderate? So 40 to 49%. Now, this is where we would then have a discussion about continuing. And we have this phrase now called permissive cardiotoxicity, which is where we allow some degree of cardiotoxicity in order to ensure the patient stays on their cancer treatment safely. We've had quite a lot of experience this in the breast cancer patients, and I think you can use a similar strategy of permissive cardiotoxicity if the patient's truly asymptomatic. Would be looking at their biomarkers and seeing how high their BNP or NT-proBNP is, and if it's relatively low, that's reassuring. Obviously, treat them with an ACE inhibitor or beta blocker. By the way, I should have said my favorite beta blocker for these type of patients is carvedilol, and there's some molecular reasons why that's the case. Carvedilol will be better than bisoprolol or metoprolol for cardioprotection. But the key message here is you can continue the osimertinib, but with much closer monitoring. And then for the milder cases where we see subtle changes in heart function, we definitely continue the osimertinib. Closer surveillance because they're now in a higher risk group, so closer monitoring with more frequent echo and BNP. Maybe have a discussion with a patient about starting cardioprotection. And that then gets personalized to the patient depending on their other risk factors, their blood pressure, their heart pulse rate, to decide what's the best for that patient. If we think about radiotherapy, I've shown you that data earlier that if you have radiation and the heart is in the radiation field for lung cancer and you have coronary disease, you have much worse long-term cardiac outcomes. So we could use the following strategy. If you've got a patient with known coronary disease, they've had a myocardial infarction, coronary bypass, or they've had stents, then of course they must be a high risk and you need to optimize them. And then for those patients who've never had a cardiac event or symptomatic coronary disease, you could use a standard 10-year risk score. And if the risk scores are in the intermediate or high risk for a 10-year outcome, these are obviously derived from the general population, then you could refer them either to the primary care physician looking after the patient, the GP in the UK, or primary care or general medicine around the world, or to local cardiology to get their risk factors optimized before and during their radiotherapy, and most importantly, afterwards, to monitor their cholesterol, their blood pressure. Obviously, education about smoking cessation is key. And if you've got someone with pre-existing valve disease or heart failure, they should have an echo so we know what the baseline is, as radiation can also accelerate those. So that's now recommended for any lung cancer patient where in the planning you're seeing that the heart will be in the radiation field. Immune checkpoint inhibitors have really revolutionized oncology and in particular lung cancer. And we started to see a range of cardiovascular problems because the Royal Brompton Hospital sits next to the Royal Marsden Hospital in London, and they've really been pioneers in introducing checkpoint inhibitors initially for melanoma and then renal cancer and of course lung cancer as well. And the biggest risk factor which is feared is the myocarditis, but we also see a range of other complications that you need to be aware of: heart block, acute coronary syndromes, pericarditis that can lead to pericardial effusions, and even a non-inflammatory heart failure. Subtype of that is Takotsubo syndrome, but actually in patients on checkpoint inhibitors for over 6 months, I'll show you now data that actually it's more than non-inflammatory heart failure.
So Alex, we're going to run out of time soon. You want to come to your concluding slide?
Yeah, okay. I'll just remind everyone we've got this management algorithm for checkpoint inhibitor myocarditis, and that we've seen this non-inflammatory heart failure. So to doctors looking after patients, be aware of non-inflammatory heart failure, but it's the late effects that we're now seeing and that checkpoint inhibitors can accelerate coronary disease. I just wanted to take 2 more take-home messages, Eric. One is you do a lot of imaging of the chest. Get your radiologist to report incidental coronary calcification. That's really important. And I wanted to show everyone your study about troponin monitoring after thoracic surgery, showing that people with troponin elevation had a much worse survival in the 5 years after their lung surgery if they had a post-operative troponin rise. And we've now had follow-on studies showing the size or magnitude of the troponin rise has also got prognostic value. So we therefore recommend long-term surveillance in cancer survivors. And I think your troponin study, Eric, shows those patients need to be a subgroup who are followed. I'll finish just by saying we have our Centre of Excellence. There's a range of different strategies to improve quality, including producing patient information. I'll remind everyone again about the ESC Pocket Guideline app. We've got a new dedicated conference, which is going to be in Vienna in June, which I hope many of you can attend. There's the QR code, and we're happy to share it through the website. And there's my take-home and summary, and I'm very happy to take questions, Eric.
Thank you very much, Alex. One of the big areas of improvements in thoracic surgeries, we're going to start operating on patients with more advanced disease. And with more advanced disease, they come with the actual osimertinibs before surgery, immunotherapy, so on and so forth. Can I ask, from our thoracic surgery point of view, how long does it take before, let's say, heart failure sets in with osimertinib treatment so that surgeons are aware when they're operating on patients with EGFR inhibitors when to screen for heart failure?
Yeah, Eric, that's a great question. I mean, now neoadjuvant oncology treatments must change anesthetic risk if they have potential cardiotoxicity. So if we look at osimertinib-induced left ventricular impairment, I look at it in two ways. So there's a subgroup of patients who are at the highest risk, their heart's got the most sensitivity, and they tend to get the problem in the first 2 to 3 months of treatment. And they often are the people who've got pre-existing left ventricular impairment, hence the importance of the baseline echo. And then more from knowledge from the metastatic setting is you then have a second wave of longer term patients that continue to present with new disease after 6, 9, 12, 18 months of treatment. So it's the long-term exposure. But if you're thinking of neoadjuvant protocols, there is that subgroup that could start to develop it in the window before surgery. So my advice would be if you've got a patient on neoadjuvant osimertinib, they've completed that phase of treatment, they're coming to the pre-op assessment that they get an echo as part of their pre-op assessment. If that's not available, then at least a BNP or NT-proBNP as a screen.
Excellent. Thank you so much. As always, there's so many questions, but not enough time for answers. Thank you once again, Alex, for leading the world in this cardio-oncology field and also for your time to present with us today. I'll be speaking next week about highlighting a few trials this year, which I think are going to be game-changing for our practice in thoracic surgery. Alex, thank you so much and have a great day.
Thank you. Have a great
Bye-bye.
day, everybody.